Today we'll be having a discussion on ward round scenario on a patient with perforative peritonitis. Presenter will be Dr. Tripurendra Rai. He's a first-year junior resident at MR Bangur Hospital. And our faculty today will be Professor Somdatta Lahiri. She'll just join in few minutes time. So let Tripurendra start. So this is the scenario. Is the scenario visible? Is this slide visible?
Yes, sir.
Okay. Tripurendra, you read this slide and then we will start discussing.
A 45-year-old gentleman presented with right upper quadrant pain for last 6 hours, which later became generalized, complained of few episodes of vomiting. Patient had history of peptic ulcer disease and was on PPI treatment for last 2 years. On examination, patient is dehydrated, pulse 110 per minute, BP 110/16 mmHg. Abdominal examination, tenderness all over abdomen with generalized abdominal rigidity. How will you proceed?
Okay. Tripurendra, this is a card you got in your examination, the ward round scenario, and maybe you are in front of one patient who underwent surgery for peptic perforation. That also is possible. But if you get this card with this clinical scenario, what do you think the patient might be suffering from? Just few possibilities that patient may have.
So the patient may have obstruction.
Obstruction means you mean intestinal obstruction?
Yes, sir, intestinal obstruction.
No, you see, before you should, when you think of a differential diagnosis, you should be thinking of more probable diagnosis, because there is some points in this presentation that pain started in the right upper coronary abdomen, and then the pain becomes generalized. And also another lead given is a patient is a known case of peptic ulcer disease. So if the patient who is a known peptic ulcer disease patient, and then he started having acute pain, what is the commonest clinical scenario you think of? Not intestinal obstruction.
Yes, sir, yes, peptic perforation.
Yes. So that is the first thing you should think, that patient with known peptic ulcer disease presented with emergency with acute pain abdomen. The most important possibility would be a peptic ulcer perforation. But you should not get always biased that patient has peptic perforation. Patient may have other diseases. Now you think of what may be the, you think of the patient who is having pain abdomen, who is having vomiting, and on examination you find patient is in shock, and patient has some rigidity in the abdomen and tenderness. So what do you think should be the other possibilities apart from a peptic ulcer perforation?
Sir, others are gallbladder perforation, rarely.
Gallbladder perforation may be a possibility, yes.
Appendicular perforation.
You see, why don't you think of pancreatitis?
Yes, pancreatitis.
Patient of pancreatitis can present with shock. The patient is presenting with shock.
Yes, sir.
So I should think that patient might have acute pancreatitis. Then patient may have acute cholecystitis. Then appendicular perforation or other hollow viscous perforation. Dr. Lahiri has joined. Yes.
Yes,
Dr.
sir.
Sundatta? Yes, yes.
Yes, sir.
This is a scenario he has raised, and I just asked him how he should think about the possibilities. He started saying that it may be intestinal obstruction, but I told him that on the background of patient having peptic ulcer disease and being present in acute abdomen, first thing you should think that it might be a peptic ulcer. And apart from this, there should be other possibilities like pancreatitis, other hollow viscous perforation, acute cholecystitis, and even an appendicular perforation. So, Dr. Lahiri, you can please continue. So, this is a thing. He should now proceed with the further progress of this patient, how to assess, what investigation should do, and how we should manage the patient. Yes, please continue.
Good morning.
Well, good morning. What other questions will you ask this patient to come to a diagnosis, possible diagnosis? Quick history in emergency.
You have given only few points. There are a lot of other things that you need to ask the patient and do further examination to come to a diagnosis.
So suppose you are in the emergency, you cannot take a full long history, but you have to take some few essential points. So what else can you ask the patient?
History of melanoma.
Okay. And
time since other NSAID use.
NSAID use, yes. Only NSAID? Will you ask for anything else?
NSAID, PPI.
You can ask that is he or he on any chronic medication? Isn't it?
Oh. Yes, ma'am. Any chronic medication.
There are many medicines which can precipitate acute pancreatitis.
Yes, ma'am.
So, okay, what else will you ask or how will you proceed?
सबसे present complaint,
Hmm.
present complaint, chip complaint, and then history of present illness. What is the time duration? All the drugs history, time of drug history.
Any previous hospitalization or surgery or
Yes,
any endoscopic procedure done before?
yes, ma'am. Any previous endoscopy or previous ERCP?
And ERCP. This is a patient with a scenario of peptic ulcer disease. You should think of how you are given a history that he is on treatment for last 2 years. So if he is on treatment for last 2 years, how was the treatment proceeding? A lot of patient does not take these medicines on regular basis. That is one important reason for peptic perforation. The patient are not taking these drugs on regular basis. Maybe he's on irregular PVI treatment. So take a little more history about his illness for last 2 years. What treatment is on? Is he taking regular medication? Is he being relieved of his symptoms? And then this pain is given a history that is 6 hours pain. And how is this pain progressing? It becomes generalized. So if the patient has got a peptic ulcer perforation, what is the characteristic of this pain? This patient pain will progress how? What do you think? What is the usual chronology of event of this pain progressing in a patient of peptic perforation?
Site,
Yes.
onset.
Yeah, what happened in a patient like this?
Site, the upper quadrant pain. Onset, gradually in onset.
No, peptic perforation pain will not be gradual onset. Peptic perforation pain will be patient having some episodes of pain will have sudden aggravation of this pain. And then initially the pain, as is described, the pain is usually in the right upper quadrant. And then as this perforation contents is getting spilled into the peritoneal cavity, the pain usually spreads along the right paracolic gutter and becomes generalized. And this patient can be generalized pain abdomen. And this patient peritonitis progress in different stages. These patient pain progress in different stages. One is stage of chemical peritonitis, then stage of bacterial peritonitis, and then abdominal distension. So you ask the patient how he is progressing. Is the pain now less than as it started, or the pain is aggravating? Whether he has got an history of fever. If this patient has got a fever, what do you think?
Bacterial.
Yes, so he is progressing to bacterial peritonitis. You need to ask this simple history, whether he has got any respiratory distress or not, whether he has passed urine or not. You see, on examination he is dehydrated. You should ask the patient whether he has passed urine or not. So you should be doing a comprehensive assessment.
Okay, other than peptic perforation, what other perforation can present with right upper quadrant pain and then followed by generalized peritonitis? Any other hollow viscous in that vicinity?
Gallbladder perforation.
Yes, it can be a gallbladder perforation occasionally.
So patient has signs symptoms for acute
And
cholecystitis.
did you ask for his addiction history, whether he had any history of alcoholism, smoking?
Yes.
All this, yeah.
Chronic alcoholic, chronic smoker. History.
Smoker, alcoholism, which might indicate that patient have associated pancreatitis even.
Okay, so now you have a patient of this status. How will you manage? Patient has generalized abdominal rigidity. So what will you do now?
Then you should also percuss this patient. On percussion, what finding may be there on percussion in this patient?
tympanic.
Tympanic means?
Air.
What is classical description?
Liver
dullness may be obliterated. Clinically, if the patient has got significant pneumoperitoneum, in that case, you may find that liver dullness is obliterated. And if you auscultate, what may be the finding in a patient like this? Auscultation?
Auscultation, bowel sound absent.
Yes. Sluggish or absent bowel sound because of peritonitis. If you do a parental examination, what will be the finding?
For rectal examinations, tenderness.
Yes. So there might be bogginess in the pelvis because of pelvic collection, and there might be tenderness on rectal examination. So these are the different things you should do in emergency and try to find out the other asset findings. Now, madam has asked, how will you proceed? Now, this is a patient in emergency. He come with this symptom and you examine and you are satisfied. Yes, this might be a case of perforative peritonitis. What are you going to do?
Resuscitate the patient.
Yes, before you send the patient to X-ray department to get an X-ray done, he should start listening because he is having tachycardia. He is having low blood pressure. What fluid will start?
NS.
So you should start with normal saline.
Normal.
Or you can start with ringer solution even. Okay. Yes. So start on IV fluid. What else? He is in pain.
NG tube.
NG tube. Yes. The stomach should be decompressed. If you suspect that is a peptic perforation, the next thing you should do is you should decompress the stomach. Start on IV fluid. Give a patient nasogastric tube. Next. They are all components of resuscitation. These are all to be done in the first go.
Folic catheterization.
Yes, folic catheterization to monitor urine output. Then
saturation oxygen.
So if you start the patient on the pulse oximeter, if he is having hypoxia, you should definitely give the patient oxygen. What else? You are not mentioning any drugs you need to give this patient.
IV antibiotics.
So you should give the patient antibiotic because of perforative peritonitis. Then you should give the patient PPI, reduced acid secretion. And analgesic. What analgesic will you like to prescribe for this patient?
So opioids, tramadol.
You see, first thing is you should avoid giving the patient NSAIDs because you are suspending peptic perforation. You can give the patient paracetamol. Or yes, tramadol you can give. A opioid like morphine should be avoided because you need to give the patient anesthesia and optimize the patient. So they are the initial resuscitative measure you take. And then what next?
Then send for chest X-ray and abdominal X-ray erect posture.
Do you really do? I mean, yes, it is done even in our hospitals, but we usually do another investigation more commonly nowadays. It's available everywhere. You can get a more holistic picture, no? Ultrasound in the presence of so much gas and fluid is difficult. It's not a very helpful investigation. Clinically, you have peritonitis. What else will you see in ultrasound? It will show fluid.
And another important thing I already mentioned is once you suspect patient has perforative peritonitis because of peptic perforation or already sorption, the best thing to do is a chest X-ray. Because often in abdominal X-ray, the diaphragm dome is not clearly seen. So to see free gas, it is better to have a chest X-ray. And in chest X-ray, find there is evidence of clear free gas on a diaphragm, then a diagnosis of perforative peritonitis is made. But sometimes the gas may not be seen well. What is the other way to see free gas? Other investigation.
Other investigations are CCT.
Yes.
CCT whole abdomen.
CT scan.
Yeah, that's what I was telling you. CT scan can tell you which perforation, which organ has perforated, or if there is any other complication. So if it is available, then why waste time on an X-ray? If it is not available, then of course you can go in for an X-ray.
But in examination, they should say at least a chest
Okay.
X-ray has to be
Okay.
done.
Yes,
Is
yes.
it available? And then chest X-ray shows clear free gas. Then question of doing CT scan become optional. If CT scan is available and then you are still in doubt about the diagnosis, yes, definitely a CT scan has to be done. So now you are satisfied that yes, this patient has got peptic perforation. What should be done next?
Then repair for
Before repair, you have done only a X-ray. You should understand that patient is optimized, patient is not having other illnesses. So that all should be done because this is a 45-year-old gentleman. What else needs to be done before you take the patient to the theater?
first resuscitate and
So how do you know the patient is properly resuscitated or not?
investigation.
Before investigation, clinically.
Patient no sign of dehydration.
No dehydration sign was there. So on starting this fluid, giving the patient a liter of fluid, you should start reassessing the patient. When the pulse rate is going down, when the blood pressure is coming up, whether he is passing urine to the optimal amount or not, whether he is feeling thirsty or not, assess his skin turgor. So one is the assessment that yes, patient is properly hydrated. And other treatment you already started, giving the patient a dose of antibiotic, given the patient analgesic, giving the patient a PPI. So what other investigation need to do? His hemoglobin might be 6 or 7. So there are some basic investigation that is mandatory to be done before you take the patient for a major surgical intervention.
लाल बैग का दिए
So what are those? What
तीन बैग का दिए
investigation?
CBC.
Yes. A complete hemogram should be done in emergency to assess number one, hemoglobin status, number two, whether the count is high or not.
And then electrolytes.
Serum electrolytes are very important. He is having repeated vomiting. He is dehydrated. So serum electrolytes are important. Anesthesia I'll ask for it. And also you should be happy that patient electrolyte imbalance is corrected. Then LFT with before LFT, think of blood sugar, think of blood urea, creatinine. So think of more common impression that is must.
Urea, creatinine, serum amylase, lipase.
See, if you get free gas under diaphragm, then I am not keeping the presence of pancreatitis. But yes, once you are sending blood, you can send for amylase lipase. That's fine. But that is not very pertinent once you are already happy the diagnosis that this patient has peptic perforation. Now we are doing investigation to assess his fitness for anesthesia surgery. So hemogram, blood sugar, urea, creatinine, serum electrolytes. You can do a liver function test to assess his serum protein status. It's already chest X-ray is done, and definitely ECG has to be done. Okay. So the other basic investigation you should do to assess his fitness for anesthesia surgery. So one should keep in mind that patient should be taken up for surgery once he is resuscitated. Suppose patient is not properly resuscitated, take the patient to theater, anesthesia is given anesthesia. What might happen on induction? Patient is not properly resuscitated and you by force take the patient to theater, give the patient anesthesia. What might happen?
Hypotension.
Yes. So if the patient is not properly resuscitated and his BP is not corrected, if you give induction anesthesia, patient will go to more hypotension, which is difficult to manage. So you should optimize the patient. What operation you will do? What is your plan for this patient?
Exploratory laparotomy, Gram's patch repair.
So what are the steps of exploratory laparotomy? How will you do? If you're doing open surgery.
Yes.
First general anesthesia, then supine position, ASSD, mid chest to mid thigh, draping the patient, and mid-line incision, skin, subcutaneous tissue.
It's okay, midline,
up to
midline
the
incision. You have
midline.
opened the abdomen. Now after that,
Now open the abdomen and seeing escape of gas.
Yes. So
from-
while opening the peritoneum, you should try to notice whether there is escape of free gas. That confirms your diagnosis. Okay.
Then suck all the fluids.
Yes.
Then retract liver, reverse retractor, and pull the abdomen down and out.
Not
pull the
abdomen,
abdomen.
Pull the stomach down.
No,
Stomach,
first
stomach. Pull
you
the
are
stomach.
assuming it is peptic perforation only. You are doing an exploratory laparotomy. You have to first explore.
Yes.
Then only, even if
Yes.
you can see
So-
maybe flakes around the duodenum, still you have to explore the abdomen. You have to see all the parts.
So you have, yes. So you are doing a exploratory laparotomy means you should exclude other pathology also. So once you open the abdomen, you will find there may be a lot of flakes around the gastroduodenal area. So first of all, before you try to find the perforative site, you should do a good aspiration of septic content that reduces the toxicity. So suck out the subphrenic collection, suck out the subhepatic collection, remove the paracolic gutter collection, remove this pelvic collection. So once you take this septic fluid out, patient will be better hemodynamically. Now, madam says that you said you will be exploratory laparoscopic. It's not only finding the perforative site. So you should find out any other pathology in the abdomen and then retract the stomach to find the perforative site. What is the most common, if you are operating a lot of patient with peptic perforation, what is the most common site of the ulcer which gets perforated in peptic ulcer disease?
D1.
D1 perforation. So D1 is the most common site of perforation.
So suppose you have a 5 millimeter to 6 millimeter perforation. What will be your approach of repair in that case? Another scenario in which you have almost a 2 centimeter perforation, and a third one we'll talk about later, gastric perforation. Peptic ulcer disease can include both stomach and duodenum. So first let's stick to
5
duodenum.
millimeter perforation
One is
versus
a
a
small
large
perforation,
perforation.
another is a large perforation. What will you do?
What is the standard technique for
Large perforation.
no, small.
A small just place momentum and suture it.
What is that operation called as?
A modified Graham's patch.
Modified Graham's patch is not placing momentum first and then suturing.
Graham's patch.
That is a Graham's patch repair. Modified Graham's patch is what?
First
goes by Sill Jones repair.
First tile suture, then
how do you suture? Suppose you have a perforation. What is the technique of suturing that perforative site? What do you do?
सबसे पहले first corner.
So take a bite. With whose suture material you use? Which suture material is preferred for closing the peptic perforation?
Vicryl.
What size vicryl?
30.
Yes, 30 or 20 vicryl is good enough. I should not take too thick suture. Okay. So polylactin suture.
Other than vicryl, what else can you use? Maybe slightly better suture.
Now available also. Monofilament suture, delayed absorbable suture.
PDS.
PDS, polydextran suture. Okay, you can use 30.
While taking the bite through the perforation, what should you take care of? You have to be cautious about one particular aspect.
The perforation is the anterior wall. So while taking the bite, what precaution you should take?
Other injury.
Not injury. You should avoid taking bite from the posterior wall. So
how can you do that? Tell me, how can you do that?
Just
particularly if you are taking the bite in the center of the perforation, don't take bite on either side in the same go. You take a bite on one side, come out to the perforating side and take the other side. so that you can now clearly see that you are not taking bite from the posterior wall. And then take bite in the corner. Which tie will be tied first? Center one or the peripheral one?
Center one.
No. If you tie the central one first, the central one is the most distant side. You have taken a standard in a small perforation, 3 suture is good enough. One in the center, 2 on either side. And if you're doing a modified ground space repair, you can take bite and then tie the corner first. If you tie the corner first, this center come closer. And then tie the central one last. Don't tie the central one first though. That is a standard description also. Madam, what do you feel?
Yes, sir.
Yeah. So tie the corner one first. And then bring out a patch of pedicle momentum, place over the suture in between, and then tie the suture loosely over the momentum. This is modified Gauss patch repair or Sillen-Jones repair. Madam said another scenario is a large perforation, large 2 centimeter perforation. It is very difficult to oppose this by a simple suturing.
So if it is a large perforation, then what will you do? The 2 centimeter perforation.
What may be the other techniques for closure of perforation? Have you seen any other technique that how large perforation may be opposed? Have you heard of a technique called serosal patch repair? What is serosal patch repair?
Just serosal.
What serosa? Which serosa is brought close to this perforative site? You cannot oppose this cut margin. You cannot bring the perforated margin close by direct suturing. So another technique for closure will be serosal patch repair. You bring a loop of jejunum. You bring a loop of jejunum and take seromuscular bite from the margin of the ulcer perforation and the seromuscular bite from the jejunum. So place that jejunal patch over the perforated site. This is serosal patch repair. In acute setting for duodenal ulcer, resection will be a difficult procedure. If surgeon is experienced, he can do a major resection. You can proceed for resection surgery. But resection surgery is not usually advisable for duodenal ulcer perforation. Madam, anything to add from your side?
Yes, sir. Actually, I could not hear anything, so I don't know what he said.
He cannot answer, but I answered on his behalf that
Sir,
in
I
such
was thinking.
situation, in the industry, you can go for a serosal patch repair.
No, but
when you
how
can
many
give-
people have really done serosal patch repair? I mean, they are
Yes,
not
yes,
experienced.
difficult.
So, what
Yes,
else
yes.
can you do? Suppose you are in emergency, you have to do something. What are the things that you can do? See, if there is a large perforation, you can treat it like a duodenal injury. Divert. So you can do one is if you have healthy momentum, which is rare. If you have a large healthy momentum, fine. Otherwise, you mobilize the falciform. You take out the Riles tube through the perforation. Riles tube tip, bring it out through the perforation, tie it to the falci or momentum, whatever, and pull it plug it. I mean, plug the hole with this fat pad and do a feeding jejunostomy and put two whiteboard drains nearby. Just divert all the fluid away from that side, let the inflammation settle, then go in again. That's what I tell my residents. What do you think, sir?
Yes, yes. Putting the
But
calcium ligament as a patch is also a form of repair, and then do a diversion.
very
Or
important to do a feeding jejunostomy.
yes,
Otherwise, you will have to go on giving that patient TPN, and that has a lot of complications. Whenever you are not sure of your repair, even if it is a small repair, you think it is very old perforation, unhealthy. In that case, always add of FJ. It helps. And after you complete the repair, if you are not doing a plug, if you are doing a normal repair, I always ask them to palpate the stomach and see the position of the rice tube tip. Because suppose it has come into the stomach and gone back, the tip is actually in the esophagus, so it will not decompress. Then you will have problem in the post-op period. Patient may aspirate due to the pressure, the sutures may give way. So always you find out the position of the rice tube tip before you close the abdomen. Now after you have repaired, what will you do? What is the next step?
After repair, then peritoneal lavage.
yes. Good
Yes,
for peritoneal lavage.
3 to 4 liters
especially
of water.
subphrenic spaces. Those are very important. Then after that,
After that, place the drain, HRPM drain.
Yes.
and otherwise, suppose you are working in a good hospital where you have a lot of instruments in your hand. In that situation, can you do something for a large perforation other than this plug?
Large perforation.
Mm. Suppose, like, sir, actually, once we had similar situation in our OT. So what I had asked them to do was just place a stapler, 60 glue stapler, distal to the perforation, close to the perforation, distal to it, staple that. So you are in a way isolating that part. You will avoid, and then you overrun that staple line, and also proximal to this perforation, and do a gastrostomy and FJ. That way, that can also be. Anyway, what you have to do is you have to prevent leakage of pancreatic juice into the peritoneal cavity, and you have to give time for the inflammation to settle.
What is the difference if you find the ulcer perforation is at the stomach? Is there any difference in approach for closure of duodenal ulcer versus gastric ulcer? You should keep in mind that duodenal ulcer usually does not turn malignant. Gastric ulcer, which is perforated, there is a risk of it being malignant.
Biopsy.
So you should always take biopsy from the ulcer margin if it is a gastric ulcer perforation. And technical closure is almost same for both gastric and duodenal ulcer perforation. But you should definitely take a biopsy from the gastric ulcer.
Which gastric ulcers are more likely to be malignant, lesser curvature or greater curvature?
Lesser curve.
Suppose you have an ulcer on the greater curvature, 2 to 2.5 centimeter. Would you repair or would you do a wedge resection?
Wedge resection.
It's easier, particularly if you have a stapler. Okay, now in which cases of peptic perforation repair would you add on a definitive surgery like acid reduction surgery, pyloroplasty or GJ?
This is a patient who has got 2-year history of peptic ulcer disease. What is the indication for doing definitive surgery in emergency setting? You got my point. This patient had history of peptic ulcer disease. This is not an acute ulcer which is perforating. So you are doing just simple closure. You are not treating the underlying pathology. What are the indications? You cannot do the definitive surgery in all situations. What are the indications for doing definitive surgery? 1, 2, 3, 4. Number 1 is patient should be stable. Number 2, there should be minimal contamination. This is a patient having 6 hours duration. So this is a patient, if the contamination is minimal, if the patient is resuscitated well, one can consider, and patient has got a long history of peptic ulcer disease. And most important is the surgeon should be experienced. The person who is doing the surgery should be comfortable in doing a acid reduction surgery. What surgery should be done? What is definitive surgery in such situation? Closure of perforation and what?
Vagotomy.
What vagotomy? There are different types of vagotomy. What vagotomy you will be venturing to do in acute setting? Truncal vagotomy. In emergency, you cannot keep on doing a highly selective or parietal cell seromyotomy. So truncal vagotomy. And if you do truncal vagotomy, you should add. You do only vagotomy, you need to add something. For peptic ulcer disease, if you do vagotomy, you need to do the drainage. So it's a peptic ulcer perforation. You should not venture in doing a pyloroplasty. You have to do a
Drainage.
what drainage? Gastrojejunostomy. Yes. But madam, I'll ask you the specific question. What are the indication of doing definitive surgery? You should be able to say the indications. Short history, stable patient, minimal contamination, and a competent surgeon who can do this definitive procedure comfortably.
And there is also one particular etiological factor for peptic ulcer. If that is the possible etiology, in that case, you should try to add on a definitive procedure. Think of the etiological factors.
H. pylori.
No. H. pylori is very well managed nowadays by medication.
Medications.
NSAID induced. If a patient is on chronic NSAID or some medication for arthritis which he cannot discontinue, in that case, it is advisable maybe to add on the procedure, definitive procedure.
What is your post-op advice? You have done the surgery, abdomen is closed. What is the post-op management of this patient?
Maintain urine output.
Maintain means what? Post-op management is keep the patient kneel orally.
NPM.
Keep him on nasogastric aspiration hourly. Keep the stomach decompressed. Give the patient optimal intravenous fluid. Continue with antibiotics. Continue with PPI. Give him adequate analgesics. And then monitoring of the patient. So this is the optimal post-op management in such patient.
When you are discharging the patient, suppose you are writing the discharge advice. Tell me what all will you advise?
Patient has recovered well. Of fluid, he has gone back to soft diet. You are discharging the patient. I always prescribe some specific treatment for such patient.
PPI.
PPI. Anything else? Because most of the peptic ulcer disease is H. pylori induced. So during discharge, you should give this patient a 2 weeks treatment of anti-H. pylori. And patient
when will you advise? Will you advise endoscopy? And if so, when will you advise?
You have done the repair. Will you advise the patient to get an endoscopy done and come to you afterwards?
I don't think so.
In acute setting, no. You have done the repair, patient has recovered. clinically, he is going back home. I start the patient on PPI treatment and also on anti-HPLV treatment. So follow this patient for about 6 to 8 weeks. If the patient is symptom-free, we should consider that ulcer is healed. But if the patient is having symptoms, you can do an endoscopy and confirm that the status of the ulcer. Now another situation. On 4th post-op, we find 300 ml of bile stain fluid has come to the drain. What might have gone wrong? On 3rd post-op day, 300 ml of bile stain fluid has come to the drain.
Should be leakage
Leakage from the
side.
There is a leakage from the side. That means the perforation you have repaired has leaked. So if the perforation you have repaired has leaked, what should you do in that situation?
Just conservative.
Yeah, that is the point now. You have to now think of the status of the patient. If it is a controlled leak and uncontrolled leak. Controlled leak means patient has some pain in the right upper quadrant of the abdomen, and whatever is leaking is coming out to the drain. That is a controlled leak. Second is, in addition to this leak coming to the drain, patient complain of pain abdomen, which is aggravating. Patient is having pain again, which is become generalized. You examine the abdomen, patient has got rigidity all over the abdomen. That means this leak is coming to the drain, and also there is intraperitoneal collection. Is the management same for these two conditions, two patients?
Different management.
Yes. If it is a control leak, you should wait and watch. Give the patient intravenous fluid, and as Madam said, if you have done a FJ, you can continue with FJ feeding. Otherwise, you should give the patient TPN. And
can you think of any other option?
Yes.
Suppose you have forgotten or you did not do an FG and the patient leaked, but patient cannot afford so much TPN. So
Yes.
how else can you feed the patient?
Any other option? Any way to put a tube beyond the perforative site?
No.
You can consider putting a nasovaginal tube.
Precast tube.
Precast tube.
If you have a good gastroendoscopist, then they can negotiate it across the perforation. And suppose at the worst, like you don't have any option, then you have to just open the abdomen, give a lavage, do an FJ and come out. Don't try to repair at that time. Do the FJ, place a drain and come out.
So if it is an uncontrolled leak, then this patient needs again a lavage, because there is a lot of leakage of content in the rest of the peritoneal cavity. So might be the drain was not draining properly. So you should do a laparotomy. Do a thorough peritoneal lavage. You can put one more drain in the pelvis and replace this drain which might be blocked. And as Madam said, there is no role for putting more suture in the perforated site. In that case, either you have to consider doing a diversion or FJ, or if you have a very experienced surgeon, he can consider doing a serosal patch repair in this situation, because a direct suture of the perforation will not be helpful in such situation. Okay. So you see, approach is important. In a ward down scenario, you should try to assess the patient, taking a good history. You do remaining part of the examination, resuscitate the patient, do relevant investigations, and then consider doing the definitive treatment and the techniques of closure. Is this surgery possible by doing laparoscopy? Yes. A lot of people are now doing laparoscopic repair of aortic perforation. The most important point is patients should be well resuscitated. Patients who are hypotensive, you infect the abdomen with carbon dioxide, the hypertension might aggravate. So for doing laparoscopic, patients should be optimally resuscitated, and you can consider doing peptic perforation closure by laparoscopic technique. You can do a good lavage. If you do laparoscopy, you can do good lavage in the whole peritoneal cavity by putting saline, do the lavage in the whole peritoneal cavity. You can localize the site of perforation and do the same suture technique as you do in open surgery. Thank you, madam.
Thank you, sir.
Thank you. Thank you.
Thank
Sure. Stop.
Thanks.
Hello. According to the way 7,500.